Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss Studientelegramms, Marcus at Home welcomes Dr. Juan Carlos Velez in New Orleans, with whom we would like to discuss the importance of urine microscopy in clinical nephrology. Dear Juan Carlos, thanks so much for being our guest this American morning, European afternoon.
Thank you, Marcus and everybody for the invitation. Pleasure to be here.
So Dr. Velez is an academic nephrologist at the Ochsner Clinical Foundation in New Orleans. His major fields of academic work are hepatorenal syndrome and diagnostic approaches in nephrology, with a special focus upon urine microscopy, where he and his co-workers have published quite a couple of papers in the recent years. My co-moderators today are Andreas Kronbichler in Cambridge and Innsbruck, Austria, and Markus Säemann in Vienna. My name is Gunnar Heine in Frankfurt, Germany. So we invited you because we are so interested in urine microscopy to share some slides with us in the first minutes, and afterwards we might have some question if that's okay for you.
Fantastic. Let's go ahead and get started. So I will get started. We're going to cover basic principles and utility of urine sediment microscopy in clinical medicine. So we're going to briefly talk about the different techniques that we have available for the clinical setting, and then we're going to go through the main findings. The presentation is centered in urinary casts. Of course, there are other findings such as crystals and cells that we will discuss but we're going to try to emphasize mostly casts in this presentation. And we're going to review the clinical utility, both in the context of acute tubular injury, as well as in more other parenchymal entities such as glomerular and interstitial disease. So starting very briefly, to remind ourselves that how casts are formed in the tubules, there is a molecule called uromodeline that is synthesized as a monomer by the cells localized in the medullary thick ascending loop of Henle. The role of uromodeline is still not fully known, but in the beginning it was considered to be sort of an adhesion molecule. Recently has been identified involved in even regulation of some of the transporters, anion transporters and cation transporters in the luminal side of the nephron. But it's interesting is that the pH in the urine, as you know, becomes more acidic in the collecting duct, and that favors the formation of casts. And we also know from work from Robert Schreier that the environment that occurs in the context of acute tubular injuries, such as increased urinary sodium, increased urinary urea, etc., also favor the formation of these monomers of Times protein or uromodeline that ultimately become cast, as we can see in this figure. And the cast could be hyaline, granular, tubular epithelial, waxy. We're going to go through those in this presentation very briefly. And I always like going to historical publications. This is one of in 1977 when Dr. Orita in Japan was the first to report using immunofluorescence that uromodeline constitutes the matrix of a cast. This image to me looked like a waxy cast, but it was reported to be hyaline at that time. It could be due to the way the image was captured. We are actually in the process of doing some work trying to learn more about the composition of casts in collaboration with a PhD scientist in the College of Charleston, Mike Janik. We're obtaining samples that have muddy brown granular casts, as seen in this figure. We go through a process of enrichment by differential filtration and low-speed centrifugation. And they sent samples to his laboratory for proteomic analysis. And just to give you a sneak peek of that, uromodeline constitutes a very small fragment, only about 4% of the muddy brown granular cast proteome, retinol-binding protein being the most abundant. And we're in the process of further investigating this with the hopes of identifying surrogate markers of muddy brown granular cast. But that's kind of topic for another discussion, but I just wanted to share with you the direction that we're going in our lab as well. Coming to the clinical application, most of the clinical labs, hospital labs are based on bright field illumination. This is an example of a finely granular cast with white blood cells on it. But it becomes a little difficult to recognize those white blood cells unless it's being inspected by an expert eye. And this is where this stain, Sturm-Harmer-Malbin stain, becomes helpful. You can clearly see in this other example on the right how the white cells become much more visible. That's something that I actually learned late in my career. I didn't know about this as a trainee until I got the stain from a friend and realized that it was much more helpful to recognize structures within casts, particularly cells, particularly white cells. Phase contrast microscopy is another important technique, which I wanted to ask you, since you're from Austria, because I learned from my German friend, Ivo Lukic, when I joined Ochsner in New Orleans, that he was inspecting the urine on phase contrast. And then I learned from Florian Bruckhammer in Switzerland that most of his images are in phase contrast. Sounds to be like a European school. I wasn't even aware of phase contrast back when I was in training in South America or even in the United States. But the beauty about phase contrast, it has very unique advantages. Here's an example of a structure that appeared to be some calcium oxalate crystals, maybe a cell inside. We don't know they're floating in the urine, but we apply phase contrast, the matrix of the cast becomes much more visible. So it's beautiful to identify a highly matrix of cast, and we can determine if we see some cluster of cells, do they belong to a cast or not. Another advantage of phase contrast clearly is the recognition of cellular morphology. In this image, a bright field microscopy, we kind of see a red cell that appears to be irregular, but we're not quite certain. When we apply phase contrast, it becomes much more evident that this red blood cell is an acanthocyte. You can see the blood protruding out of the RBC. You can see the halo around the cell, which is generated by the optics and allows you to visualize the cell very well. Polarized light is another feature that is important to have available in your clinical laboratory. Here, example of uric acid crystals. The morphology sometimes is very obvious, even without those polarized light, but in this case, you can see it better. Another advantage of polarized light is for the recognition of lipids. On the top panel, you see a lipid cast. Sometimes if the size of the droplets is similar to an RBC, it could be confused with the red cell. But we apply the polarized light, we can see the Maltese cross sign clearly recognizing lipids inside the cast. And then dark field illumination is the one that perhaps, if you push me, I would say you can probably avoid it and still obtain enough clinical information. I particularly find it useful when you're looking at a very dense sediment with multiple casts. It becomes more easier to identify the cast at a low power field. Here's a 100x view of muddy brown granular cast. You can see because of the dark background, they stand out very nicely. Also, acanthocytes, dysmorphic RBCs are very nicely visualized by dark field illumination. But again, these features are not features that you cannot obtain with other techniques such as phase contrast or bright field illumination. But I wanted to show that because it's important that having bright field illumination, phase contrast, polarized light present is really essential to be able to conduct a complete examination of the urinary sediment. Now move on to some of the clinical utility, which is the bread and butter of what we do at a hospital every day, starting with acute tubular injury. So urinary microscopy was started having sort of a resurgence when Mark Perazella and his collaborators at Yale published this paper in 2008, where they looked at the diagnostic value of urine microscopy. Up until that time, there were a few reports in the literature, one from Canada and India, with a very small number of patients where there was suggested some benefit, but it wasn't really rigorously examined. And this study, 231 patients were included that had acute kidney injury. and the cause was acute tubular necrosis versus prerenal isotemia. They conducted urine microscopy. The investigators were blinded to the clinical history. They came up with this score system where they scored the sediment based on the number of renal tubular epithelial cells and the number of granular casts. And the bottom line is that if the score was 2 or higher, there was an increased odds ratio for diagnosis of ATN. And the diagnosis was confirmed by a different team of investigators in a retrospective fashion, chart review. That was the way they did it. And when they looked at the actual positive predictive value in a patient with a high pretest probability of ATN with a score of greater than 2 was actually 100%. Similarly, for a patient with low pretest probability of ATN and a score of 1, it was 91% negative predictive value. So very good performance in this test. Now, again, the caveat is that the way they confirmed the diagnosis was still chart review. So that's why recently we wanted to go a little bit further and have histological confirmation of the diagnosis, because ultimately, if you don't have biopsy-proven ATN, it all becomes sort of a clinical judgment and not so much of a gold standard. So in this study, we had 371 patients that in our database with AKI stage greater than 2 or greater, where we took a subset of patients with kidney biopsy. In this particular case, were 49 patients that had kidney biopsy, and we're looking for those with multi-branch granular casts. And what we observed is, as you can imagine, the 100% of the patients who had multi-branch granular casts, 100% of them had ATN on the biopsy with a positive predictive value of 100% and specificity of 100%. It is not good rule-out test. You can see here negative predictive value only 62%. Not finding multi-branch casts, it doesn't mean ATN may not be present, as you know, but it's important that this is the first time that we have actual formal demonstration of the relationship between granular casts and tissue-proven acute tubular injury. In the same study that was done with our trainees, Varghese and Rivera and Ochsner, we're also interested in this relationship between fractional excretion of sodium and multi-branch casts. The reason being that ordering urinary sodium continues to be the most common test order in our hospital in many places throughout the United States. And we wanted to see how do they perform in terms of identifying ATN. So here it is. First of all, out of 270 patients, we looked at those who had greater than 10% of low power fields containing at least one multi-branch granular cast, and it was 43%. This is obviously an enriched population because this is for patients that were sent to the nephrology consultation service. So this is not all comers. So obviously the frequency of ATN is a little bit higher than expected. But what we found is that looking at those with greater than 50% multi-branch cast below power field, almost a third had a fractional excretion of sodium less than 1%, which the book says that's consistent with prerenal isotemia. We just wanted to highlight a discrepancy, and we actually performed some concordance study showing that there was no concordance between the two, and we can probably talk more about it if there's time at the end. Another work that our team did at Ochsner is looking at the diagnostic utility of serial microscopy. So let's say you look at the urine on day 1 and you don't really find much. Is there any value of going back and repeating the microscopy? So here is sort of a summary of results of our study, where you can see in the blue part of the pie chart, 51 patients were identified with ATI, acute tubular injury, on the first microscopy, 42% of them. And then patients underwent a second or a third microscopy, and 11% of them were found to have evidence of acute tubular injury, and even 3% at the third microscopy, which was conducted in a small fraction of patients. So this is one example of a patient who day one had a blunt sediment, and we looked at the urine on day 4. We found muddy brown granular cast. So 23% converted to ATA. So I think the importance is when we look at who were the patients who are likely to have a change in their cast abundance, were those who the acute kidney injury wasn't getting better. In other words, if the acute kidney injury is still worsening or not getting better, and the diagnosis is still not clear, appears to be a value of repeating microscopy. Outside of that setting, it may not be necessary. Waxy casts is another interesting finding. They are characterized by this more of a bright appearance with birefringent and noticeable edges. Sometimes they have cracks. They can appear straight. Sometimes they can appear with crack in the edges, or even convoluted, as the one showing in those images. In our center, we looked at a subset of our cohort of 167 patients, where 28% of them had waxy casts. One of the important observations personally was that most of the books that I have read at that time said that waxy casts were an indication of chronic injury to the kidneys, so that consistent with advanced CKD, etc. What we found is 70% of the patients in this series did not have any evidence of chronic kidney disease. It was pure AKI, probably pure acute injury. So that was one of the first observations. This is the idea that waxy casts are only chronic, only found in chronic diseases, clearly not true. And then we looked at the sort of the prognostic value of this cast, and we saw here that waxy cast had a same sort of a relative risk association with need for dialysis compared to muddy brown granular cast, but the combination of both appeared to have even a stronger risk, as you can see here. And in the bottom figure, we also saw the greater the number of waxy casts, the greater the probability of requiring dialysis. So this is work that is in the process of being written in a manuscript. Hope to share it later this year. As was mentioned in the introduction, one of my areas of special interest is hepatorenal syndrome and acute kidney injury and cirrhosis. Microscopy in this setting is unique because there's an endogenous pigment called bilirubin, as you know, and interpretation of the urinary findings requires sort of extra attention. I'm showing here in the top panel different images of casts. Starting on the left is a hyaline cast with a faint bilirubin stain. The second one is a little bit brighter staining of that cast. It still appears to be hyaline. The one in the middle is clearly a granular cast, but it does have some bilirubin staining. And then finally you get to a muddy brown granular cast seen under bright field, and the last one is also muddy brown cast under dark field microscopy. And what I wanted to show is just that, you know, the first couple of even the third cast shouldn't be cast that necessarily should be interpreted as clear-cut acute tubular injury. When you review reports of hepatorenal syndrome in the old literature, even when the autopsy showed normal renal parenchyma, the investigators reported a few bilirubin stain casts that they don't have images to show, but I suspect they refer to these casts that they were not quite as pathognomonic as muddy brown granular casts. Renal tubular epithelial cell casts can also be found in patients with cirrhosis. I'll show you some numbers in a minute. And if you use polarized light, they can sometimes stain green due to the bilirubin pigmentation. We also have some other crystals, such as leucine crystals on the top panel. Here is also bilirubin crystals to the right side in dark field, as well as bright field. So bilirubin and leucine crystals can be present as well, and we have to recognize them and not confuse with other structures. So one of our collaborators in part of the Harmony Consortium that we investigate hepatorenal syndrome. Andrea Allegretti in Harvard reported this paper in 2015. Essentially, they say, okay, we take the criteria, ascites criteria for hepatorenal syndrome, and look at the definition of HRS and ATN. This is what he got. He got a split of 29% of patients that had HRS, 30% ATN. And then he went on and performed urine microscopy. And for those who dark granular casts were found, the diagnosis was converted from HRS to ATN. And that happened in 22% of the cases were reclassified as ATN. We recently presented a similar effort we did at our center. We presented in Kidney Week in Orlando just a couple of months ago. And for us, it was actually 53%. So just to show that addition of microscopy could unmask cases of acute tubular injury that perhaps could be inadequately treated as HRS. And yes, I mentioned the presence of renal tubular epithelial cell cast. One of the initial observations we had is that when we looked at a cohort of 606 patients that had urinary microscopy performed, we separated those with AKI due to cirrhosis, 185 patients, versus those without cirrhosis, 421 patients. And you can see a remarkable difference in the percentage of patients with renal tubular epithelial cell cast. And we don't really know why. We speculate that perhaps the bile salts that are present in the tubules are leading to more sloughing of the cells, and they come out in the urine. Bilirubin is been reported technically to be a benign molecule, an antioxidant molecule. But this is the observation. And we further looked at those 185 patients with renal tubular epithelial cell cast, and we found that the serum bilirubin tends to be higher in patients with cirrhosis, with 25.9 milligrams per deciliter. So the higher the bilirubin, the more likely to find this cast. Now, what is interesting is that Jose Antonio Poloni in Brazil looked at this cast in a different way. They just essentially went to the hospital laboratory and looked at everybody with a urinary microscopy with or without AKI. And in his observation, there was no really relationship between having or not having AKI and the probability of finding these casts. You can see here for those with hyperbilirubinemia categorized as moderate to severe, the percentage of patients with this cast was the same and was high. So this is telling us perhaps that this cast might be an indication of some subclinical tubular injury, but we may have to be careful to link them with the cause of AKI. And that obviously is still work that we're going to try to replicate by looking at patients in our center without AKI. And the last aspect that I wanted to show with you today in terms of acute tubular injury is sort of one example of drug-induced acute tubular injury where microscopy can be helpful. So this is an image of what appears to be a granular cast or a multi-granular cast at a 400X. However, when you look at this cast in detail, you start to see some unexpected type of shape inside the cast, and we apply polarized light. We all of a sudden see that everything is bright. And again, a granular cast should not be polarizing like this. So clearly, this is a pseudocast and appears to be some type of crystal of unknown origin. Asking back, this patient was actually exposed to ciprofloxacin, so that raised the flag. And then we have another case that is perhaps even more convincing because you have this cast with a structure inside the cast of unknown nature, and we applied polarized light. It was really bright and clearly some type of material embedded in the cast. This patient was also exposed to ciprofloxacin crystal, ciprofloxacin, and looking at the literature of the case reports, the morphology was very similar. So this is just one example that without polarized light, this case could have been missed, and just this cast could have been interpreted as just random granular casts. In this particular case, the patients ended up having an injury due to ciprofloxacin. So now let's move on to glomerular disease and interstitial disease to see the utility of urinary sediment. Starting with this paper from Giovanni Varghese in 2005, one of the seminal papers. In this case, he looked at the difference between proliferative glomerulonephritis and non-proliferative glomerulonephritis. Proliferative meaning your infection-related glomerulonephritis, lupus glomerulonephritis. I think he also included ANCA vasculitis in this group. Non-proliferative were considered things such as membranous nephropathy, focal segmental glomerulosclerosis, etc. And the first observation here is the presence of red blood cell cast in the blue column here in the middle. It was much more likely to be present in those with proliferative glomerulonephritis. Quite impressive percentage, 85%. That's not, in our experience, we don't find it to be so common. And then when we looked at other findings here, they were not as different as the RBC cast. We can see here the image. And then white blood cell cast, I want to bring this to your attention. Here, proliferative glomerulonephritis, 11% compared to 4% of non-proliferative glomerulonephritis. So combining white blood cell cast, red blood cell cast, and red blood cells, the odds ratio for a proliferative glomerulonephritis is almost 10. So very high indication. So essentially, this is what is being called as an active sediment, presence of dysmorphic red blood cells, white cell cast, and red blood cell cast. This is a more recent study looking at 126 patients with either lupus nephritis or IgA nephropathy. This is in Asia where IgA is very prevalent. They were trying to see, can urine microscopy help us and distinguish the two? And as you can imagine, the answer was no. But I'm showing this study because to me it was interesting to see the proportion of patients with lupus nephritis with white blood cell cast and IgA nephropathy with RBC cast. In general, you can see that the numbers are very similar. So this idea that RBC casts are unique for GNs and white blood cell casts are not so unique, as Varghese reported, started to be a little bit different here in this study from China. We're going to come back to the white blood cell casts in a little bit, but let's just talk about this sort of a pathognomonic dysmorphic appearance of red blood cells, which are called the acanthocytes. This is a very really fascinating image from Color in the UK. On the left panel, an RBC trapped in the electron microscopy as it crosses through a disrupted glomerular basement membrane. And this is one of the images that perhaps suggests that the formation of these blebs occurs at that time. But again, this is all speculation. We don't have clear understanding why those protrusions are formed, but definitely become very, very unique, as you can see in this 2000X image. And the seminal publication, once again, comes from Central Europe using phase contrast microscopy, as was mentioned earlier. This guy, in this case, was Hans Keller, 1991. He conducted a study looking at 331 patients, 143 with glomerulopathies and 187 without glomerulopathies. And what he observed is that the percentage of acanthocytes greater than 5% had a strong positive predictive value for glomerular disease. He identified it in 52% of those patients. He also looked at the RBC cast and only found it in 24%. Again, more consistent with the report from Asia, not so much from the report from Varghese with a positive predictive value of 80%. So this is an important slide because it's to highlight that acanthocytes are much more sensitive than RBC cast in when we try to identify glomerular diseases, particularly proliferative glomerulonephritis. And this was not correlated with creatinine, meaning this, whether the patient had or didn't have AKI, it didn't matter in that study. We have collected some of our own data at Ochsner. Here is on a cohort of 70 patients that had either glomerulonephritis or non-glomerulonephritis, meaning ATN, or nephrotic conditions such as membranous nephropathy or diabetes. And our actual sensitivity was a little bit higher than color so far, with 86% of patients where we found acanthocytes. Specificity 86 and sensitivity was actually 74. So color had 54 and we had 74, a little bit more. And then out of those patients, 6 out of 43 that had acanthocytes and the biopsy didn't show, let's say, ANCA vasculitis or didn't show some type of IgA nephropathy, 6 of them had diabetic nephropathy, which is something that was surprising to us because some authors have suggested that in diabetic nephropathy, you may see RBC cast, but you shouldn't see acanthocyte. Well, we found it in 6 of these patients. So if you count all glomerular diagnosis, then you remove those 6 patients, those with tubular disease or without a glomerular disease, and none of them had acanthocyte. So in terms of evidence of glomerular disease, the specificity is 100%. So finding an acanthocyte is 100% consistent with glomerular disease. Whether it comes from nephritic or diabetic nephropathy, you can't tell. We're starting to look for some other additional findings in the sediment, but that's what we found so far. Now, recognition of these acanthocytes is critical. Here on the left panel, you have a phase contrast image of multiple acanthocytes that I'm circling here in orange, some of them with 1 protrusion, some of them with 2. And then on the right hand, you have some crenated RBCs, very different morphology. And you also have some budding yeast where what is typical in budding yeast is that the protrusions are large. Sometimes they have an oval shape, and there is not a hole in the middle of the yeast. RBCs, you can see on the left, true acanthocyte is like a ring form with a hole in the middle and a protrusion. The hole in the middle is not seen in budding yeast. But this is a very common. We have actually cases where the hospital laboratory reports budding yeast in abundance. We looked at the urine, and all we see are acanthocytes, and that happens in many places. Jay Seltzer has shared some cases in his center in Missouri as well. So this is why it's important to have careful inspection of the urinary sediment. Now, what about interstitial nephritis? And interstitial nephritis has been really not well studied, very, very limited literature. Again, it's not, we often make clinical diagnosis of interstitial nephritis, treat patients with steroids, stop the medication, and we don't always biopsy. That could be the reason. But here's a study with 21 patients by Giovanni Varghese once again. And what he reported is here are the percentage of cast, hyaline, granular, white blood cell cast, and RBC cast. So the number of RBC cast that he found was actually higher than white blood cell cast, which is what the book said. White blood cell cast should be consistent with interstitial nephritis, where he found RBC cast to be more common. Well, that was interesting because I haven't really, I don't remember conversations with any of my teachers telling me, oh, the paper by Varghese showed this. The books say white blood cell cast. Even when we take when we administer examinations for trainee, it's a classic question. A patient took this drug, the urine showed white blood cell cast. What is it? AIN. Okay, so we have looked at this very recently in our center. Now we're continuing to build our cohort of patients who have clinical data and urine microscopy at the time of the AKI consultation. Now we are up to 683 patients. And we looked at those who had biopsy, which was only a subset of 103 patients. And with them, we look at the diagnosis. 42 of them have glomerulonephritis. The majority were crescentic post-immune glomerulonephritis, followed by IgA, lupus, and other GN such as C3 glomerulonephritis or infection-related glomerulonephritis. 12 of them had acute interstitial nephritis. White blood cell counts were found in 37%, 36% of patients. Again, you may say, well, that's huge. Well, I'm just talking about patients who underwent biopsy. So clearly, this is enriched population of patients that you are suspecting IgN or suspecting AIN, you're more likely to biopsy. So 36% of them white blood cell pass. And what we found is that the most common diagnosis with those white blood cell counts were actually glomerulonephritis. With a positive predictive value is not that good. The positive predictive value is actually terrible for acute interstitial nephritis. So I always tell my trainees, if you suspect AIN, don't spend hours or so searching for a white blood cell cast. A white blood cell cast, in our experience, it is not an AIN at all. It's actually more common in GN. And it's not very different than what has been reported if you look carefully. I'll try to show you today. And the images of the white blood cell on the right-hand side. Bottom panel shows actually a polymorphonucleated cells as well. So the conclusion was the urinary blood cell counts are commonly associated with GN rather than AIN. It's a bold statement that tries to challenge the textbook. And we're going to try to formalize this application hopefully later this year. And just to find a couple of slides, pyelonephritis, this is a paper that has only been published in German, so you guys don't have a problem. I do, but I have my friend Ivo Lukic and our faculty translated this paper for me. Essentially showed that pyelonephritis, these are patients who had actually histological demonstration of pyelonephritis, very unusual study. And they found white blood cell casts to be present in all cases of pyelonephritis. So that's another thing that gets missed in the discussion. Okay, and then finally, I'd like to share with you this vacuolar casts, which are sort of a new kid on the block for us, a type of cast that I wasn't aware until the last recent years. You can see the characteristic of this large vacuoles inside the cast of different sizes. If you apply polarized light, you will not see Maltese cross. It's not just a lipid cast. Should not be confused with a red blood cell cast either. And this is under bright field, and the right-hand panel is under dark field microscopy. And we have observed this cast, and we have seen some of our colleagues on Twitter posting images. So we have compiled a series of 18 cases from United States, Brazil, and India, as you can see here. And the overwhelmingly predominant factor is that these patients have a severe proteinuria, advanced chronic kidney disease for the most part, most of them diabetic, at 3+ protein in 95% of the patients. So it appears to be sort of an ominous sign. We're not obviously clear how they are formed. We think it probably come from tubular epithelial cells that engulfed protein and become stressed and form vacuoles. But it's just important to be aware of this cast. There's only one paper in literature with a case report. We hope to be able to present publish this series later this year. And 11 of these patients actually biopsy-proven diabetic nephropathy, few focal segmental glomerulosclerosis, and thrombotic molecular angiopathy. So this is just a summary, just to highlight the main points that I try to share today. Detection of muddy brown granular cast, we can say now that it's pathognomonic of acute urinary injury because we have biopsy studied. What's the cast can be seen in AKI, not just in CKD, and are associated with worse prognosis. Acanthocytes are better detected with phase contrast and are very sensitive and specific for glomerular disease, particularly glomerulonephritis. The Sternheimer-Malbin stain enhances the diagnostic utility of urine microscopy. WBC casts are more likely to find in GN or pyelonephritis rather than AIN, as is commonly presumed. RBC CAS can be found in glomerulonephritis and interstitial nephritis as well. And polarized light is essential for proper identification of crystalline drugs with potential for causing acute kidney injury. I think I'm going to stop here, and I'll be happy to address any questions.
So thanks so much for the splendid presentation. Before I leave the mic to Andreas and Markus for the discussion, I would just, for patriotic reasons, like to point out that you referred to Hans Köhler. Hans Köhler has been the head of department of nephrology in Homburg, Germany, where we actually started with our podcast. So it's,
oh, wow.
As we say in German, a Heimspiel for us. Thanks so much. And with that, I leave the mic to Andreas and Markus.
So Juan Carlos, this was phenomenal. Very, very nice presentation and oversight, and thanks for all the work you're doing in this field. So my first one is a very simple one. So how many centers in the US are doing it like you do? Because this is like a really difficult method, I think, to implement and also to teach junior doctors.
Yeah, no, thank you for the question. I think it's not a high number. I would say that we do it. Jay Seltzer is a private practice nephrologist, not really in a university. He was an academic in the past. He's an academic by heart, but he's in private practice in Missouri. He visits certain fellowship programs to provide workshops and lectures, but those programs don't have them themselves. It's Jay who goes there. I think some labs that I had opportunity to be invited and I kind of share what we do, they have tried to replicate that. I know the Mount Sinai group has done it. Ohio State University, I think they have a lab. But I think it's going to be a handful of labs in the country who have the equipment, the whole setup of microscopy, image acquisition, as we do. So yeah, it's we use that as a marketing tool to try to attract trainees to our program. But yeah, it's something that it should be much more so disseminated and more common, but it's not. Unfortunately, in many places, I am aware actually training programs where the fellows don't even have a microscope, which, believe it or not, to look at this. So it's really very heterogeneous across the country. I'm not sure how it's in Europe or in other parts of the world.
When I started my training back in Austria, so we had a technician who was doing it, and she reported that. But then this was left over to the central laboratory, and they did automated interpretation. So it's very, very inaccurate, honestly, what you get out of that. And now moving to the UK, it's really desperate because we are not working with urinary sediment at all. So you just get your urine dipstick, and you can do urine culture to say or to ask if there are red blood cells. But of course, this is very unspecific. And it's kind of ridiculous, to be honest, because you have clearly shown. So one of the most difficult things, I guess, in renal medicine is, at least for me, has been, is this hepatorenal syndrome? Yes, no. Or is this, some kind of bystander? And you clearly showed, you can basically reclassify a patient as having ATN rather than hepatorenal syndrome. And of course, the treatment is a complete different one. So I think it's phenomenal to see what you can do with this tool.
Yeah, maybe I can also follow with that now as president of the Austrian Society of Nephrology. We have it in the curriculum of our nephrology trainingship, and to be honest, it's left to the ambition of some singular nephrologists. And I tried to manage that also in our center, and there are one or two who are really ambitious. Also some of them maybe from Twitter, but it's not a general education, so to say. So there's a lot of room of improvement. And in times of Zoom meetings and so on, I would find it fabulous if they could join in such a training, if you could handle that on an international basis. And there are also reports there was no correlation between advanced nephrologists and the young nephrologists, or inverse relation. So it's ugly when we see what results we can get in the early management of vasculitis, and even as you have shown in the AKI. So that's the situation. I think it's more or less the same in all European countries. Also, I do not know exactly what's going on in France or Italy or so. Yeah. And therefore, my question is also the future. Do you see, because you show mass spectrometry analysis, could there be a step forward to a more automated possibility with mass spectrometry and maybe, you know, artificial intelligence or neural networks or what else, that you not only rely on the subjective experience?
Yeah, thank you for the question, because we are very interested in working on that area. As I show you, one of the questions we have, okay, so if your microscopy is not available because of logistics, lack of expertise, lack of having a microscope available, because, you know, busy clinicians don't have the time to do it, they cannot get reimbursed for the work. What can we do about it? So proteomics is a way to capture proteins that are contained in the Cas, and we're hoping to be able to identify proteins that are specific for muddy brown granular Cas. As an example, we are going to work with other Cas so that a test can be ordered to the laboratory, and the laboratory reports protein X being present. It can give us confidence that if you were to perform microscopy, you could find muddy brown Cas, sort of an ATN test diagnosis. So we're working on that. Artificial intelligence is obviously something that is getting a lot of attention in many areas, and not just in medicine. And we actually work with one of our fellows, Josian Flores Santiago, very technically savvy young man who had developed a computational model. Essentially, he trained the computer, shows images of we work specifically with muddy brown waxy Cas as well as acanthocytes. So he's trained as a acanthocyte, feed the model with 100 images, and then the model can actually be trained, and you essentially develop an app, and you put a camera on the image of this microscope, and the program can recognize and label the finding. So clearly, this is work that still needs to be developed fully, but we are looking to find that. And lastly, I will mention that we have this observation with Jay Seltzer that we can leave pellets and sediment pellets on a rack at room temperature in the lab, and come back the next day and look at the urine and still find most of the same structures, even 2 days later, 3 days later, even a week later. So the notion that you have to refrigerate the urine, if you don't look at it immediately, is all gone. It's not true. That may apply for infection, looking for bacteria. That might be a problem. But for findings in nephrology, you don't have to get it necessarily very fresh. And that opens opportunities for us to kind of have centers to ship us their urine pellets, so we can conduct a microscopy here as well. So just try to find ways to make this more available and exploit the advantages of microscopy. And just to kind of add what was mentioned earlier, Marcus and Andreas, that the lack of expertise across the board, you know, this is something that it is not part of the curriculum standard. You know, you look at the training in nephrology, they have standards for procedures, for putting catheters, for learning dialysis, nothing really structured for microscopy. I think we have an opportunity also to improve that. It's not an expensive test. You know, a microscope with the basic elements probably goes for $5,000, $4,000 or euros. So it's not very expensive in terms of what can you obtain with that.
Mm-hmm.
What about reimbursement of, you know, microscopy in the US? Do you get any money for that?
No. So what we do these days is we essentially account for time spent. So if you look at a patient and it takes 25 minutes and you end up spending an additional 25 minutes on the microscope, that is a 50-minute visit. So we try to elevate our codes so the reimbursement goes up. Unfortunately, we don't have, we're not charging for the actual technical test itself, because pathology charges for urinalysis. So that is one of the reasons why private practice nephrologists don't want to do it, because they're not going to be paid for it, as you can imagine. So that is something that also needs to be addressed, because some of the things that we do are not standard hospital laboratory. They don't use polarized light as standard. They don't use phase contrast as a standard. So what we do is different. So we have already begun exploring ways to charge our what we do at a different code as a special test. It's not going to be a lot of money, but you know, it adds up when you do hundreds of this throughout the year.
So just one last question from my side. You showed that in diabetic kidney disease, you found in 6 out of 43 patients with CKD, basically acanthocytes. Do you have any baseline characteristics which would indicate, you know, acanthocytes like severely impaired kidney function or high albuminuria in these cases? Because that's a kind of spectacular finding in my eyes.
Yeah, no, we have not found. We have looked at these 6 patients to see if there's a common denominator among those 6 patients respect to the other ones, and nothing stood out. We haven't done a very rigorous analysis. We just kind of review the charts and try to see the obvious things. In a couple of patients, I was very intrigued because one of the patients who had acanthocyte, the biopsy reported a microaneurysms in the glomerulus. So as you can imagine, oh, there you go. There's something about an endothelial cell being damaged that a GN becomes nephritic, and you can see acanthocyte. But then the other biopsies didn't report those microaneurysms. So it made me think maybe they are there, just this is a sample error of a biopsy. But other than that, the degree of proteinuria, the degree of mesangial expansion, the degree of tubular interstitial fibrosis doesn't appear to be unique. But what I can say is that we found acanthocytes in these cases of diabetic nephropathy. There are very few scattered. It's not like when you have a patient with post-immune GN or IgA nephropathy where every other red blood cell is an acanthocyte. It's pretty clear.
They have a retinopathy because the diabetes is normally having leaky endothelia. So maybe they also leaky.
It's a good question. I haven't really looked for retinopathy. It's something that definitely worth exploring.
Okay.
So maybe last question from my side. Are there any websites or other internet tools that you would recommend for our colleagues who now become interested in this field? Surely they should follow you on Twitter. But are there any other items to recommend?
Yes, thank you. Yeah, Twitter is a platform that we recommend for sure. We use the hashtag urinary sediment and the hashtag urine microscopy. That's the hashtag Jay Seltzer and I use. There are other individuals on Twitter, such as Jose Antonio Poloni and others that post nice images as well. And there is a website called Renal Fellow Network, where we share. There's a chapter, sort of a section called Urine Sediment of the Month. It's not coming monthly, but every other month or so we post something related to urine microscopy. And I think what I would tell the junior or anybody, even the senior nephrologist interested, there is never late to learn. This is a skill that when I was a resident, wasn't even aware of this, to be honest. I knew something as a medical student, as a resident. When I started rotating with a nephrologist, he started showing me, he actually would look at a urine and would go down to the microscope and he'd show me something. He'd like, look here, there's a cast. And I would look and I was like, oh, okay, I believe you. I wasn't sure what I was looking at. And they were like, all right, let's go see the next patient. It was a very, what I learned at that time, it was important, but I didn't see I didn't understand what we're looking at. I had to go to the book and kind of review. Then as a fellow, very similar, I would go with my attending physician and they would look and it's like, and the attending would say, I'm not sure what it is. Let's just forget about it. Let's go see the other patient. So there wasn't really much knowledge and expertise. And then I started doing research in my previous job in South Carolina. I had access to a microscope, and I have seen how our pathologists have these beautiful screens and they share their path. And I started thinking, maybe I should do that for microscopy. And it sort of started self-training. I bought my, set up my microscope, I started learning, looking in the urine. And that kind of over time gave me the skill. And of course, Twitter opened a world for all of us. When Florian Bruckheimer started posting pictures, I was like, wow, this is a great idea. And then the whole process started. And I'm still learning. I can tell you that I know more than I knew last year and 3 years ago. So it's really a lot of sort of a determination and appetite to learn. And yeah, those online tools that I mentioned, there's a good book, the Atlas of Microscopy, that I would recommend, by Haber, Haber. It's the best book available. But nothing beats, at the end of the day, looking at the urine. You know, every AKI consult, just look at it, get somebody to look at it, share images. Jay and I are always available. Sometimes we get images sent via private message, and we're happy to provide some input as well and kind of help others learn about the skill.
Thanks so much. It was fascinating. So thanks so much for taking the time, for being our guest. And I'm sure that there will be more people interested in urine microscopy in Austria, Switzerland, Germany after watching this video. Thank you.
Thank you very much, Gunnar, Andreas, and Varghese. It was a pleasure.